So today we'll be talking about the obstructive airway disease, the nursing management, the nursing care of the obstructive airway disease, very commonly seen as COPD that we come across in our ICUs, even in wards. A lot of time you see those patients presenting to emergency. Rishi, am I audible?
Yes, sir. Yes, sir.
So Neil, I'll have to ask you to change the slide, right?
Yes, sir.
Next, please. Next. Okay, so friends, this is how, what, and how we'll be going through the next 40 minutes. First, we'll try and define what is an obstructive airway disease. Most of the time, which is a chronic condition. So what is a chronic obstructive pulmonary disease? How do you classify them? The pathophysiology and the epidemiology of the disease, the causes, the clinical presentations, how we can prevent them, what are the complications. Then comes the assessment of such a patient and diagnostic findings. And we'll be essentially talking about the nursing management, not the medical management, but the nursing management, which will include nursing assessment, diagnosis, the goals and the planning, the nursing priorities and the interventions. How do you evaluate whether your interventions had any benefit or not? And then eventually, nurses are also involved in the care of these patients at home and at the time of discharge. One of the most important things that we often forget when we talk of these clinical matters is the documentation. At the end of it, we'll have a few quiz questions and we'll see if we have made any difference to our understanding of the nursing management of the chronic obstructive airway disease. Next. Next. Okay. So as I said, we'll start with the definition. So what is COPD? What is chronic obstructive pulmonary disease? It is a condition of chronic dyspnea with expiratory airflow limitation. Remember, it's an expiratory airflow limitation that does not usually significantly fluctuate. That is the GOLD criteria, GOLD initiative, which defines chronic obstructive pulmonary disease as a preventable and treatable disease with some significant extrapulmonary effects that may contribute to the severity in individual patients. So it is preventable, it is treatable, and the severity may also be affected by the extrapulmonary events. Next. So when I talked about classifying this COPD, they're essentially classified into two, a chronic bronchitis and an emphysema. As you can see from the picture, a chronic bronchitis guy will be a fat, bloated person looking blue as in cyanotic. So they are usually called as blue bloaters. And an emphysematous patient, an emphysema patient will be very red, plethoric, thin and frail. So they are called as pink puffers, right? If we go into more details, the blue bloaters, that is the chronic bronchitis. How I remembered in my earlier days, because very commonly we would get confused who is a blue bloater, who is a pink puffer. So I remembered bronchitis as a bloater. So B for B. So chronic bronchitis are blue bloaters. As the name says, they'll be overweight, cyanotic, they'll have peripheral edema, and obviously when you listen to their chest, they'll have rhonchi and V's. These patients will also have a raised hemoglobin. This chronic bronchitis is defined, it is a clinical diagnosis. It is defined by daily production of cough, as in productive cough, sputum should come out for 3 or more months in a year for at least 2 consecutive years. So for 2 years, if somebody is having daily production of cough, a productive cough for 3 months or more, then you call them chronic bronchitis, a clinical diagnosis. Whereas the emphysema, which it's a pathological diagnosis, where there is a permanent destruction and enlargement of the bronchioles distal to the terminal bronchiole, or the alveoli distal to the terminal bronchioles. So if you look at X-ray, you'll see a hyperinflated chest X-ray with flattened diaphragms. That's because of the permanent destruction. Next. So as I said, chronic bronchitis is a disease of the airways and is defined as a presence of cough and sputum for at least 3 months in 2 consecutive years. They're also called as B for bloaters. So they're also called as blue bloaters. Pollutants or allergens, what they do is they irritate the airways, which leads to the production of a lot of sputum by the goblet cells or the mucus secreting glands in the airway. So any allergen, which may be a smoke or an environmental allergen, they irritate the airways and cause the production of these sputum. And they, a wide range of viral or a bacterial or a mycoplasmal infections can actually give you an acute episode of bronchitis in these chronic bronchitis patients. Next. Emphysema, as we discussed, there is a permanent abnormal distension of air spaces beyond a point which we call as terminal bronchioles, and there is a destruction of the walls of the alveoli. So there is a permanent dilatation. These patients are also called pink puffers. There is an impaired carbon dioxide and oxygen exchange, and this is because of the destruction of the walls of the over-distended alveoli. Next. So what is the pathophysiology? Most of it we have actually discussed. So as I said, in COPD, there is an expiratory airflow limitation, which is both progressive and is associated with an abnormal inflammatory response of the lungs to noxious gases, which is very simple. If you look at it, it is an expiratory airflow limitation. Air bahar nikalne mein there will be difficulty, which is both progressive and is associated with an abnormal response of the airways. Or it's an inflammatory response that occurs throughout the proximal and the peripheral airways, lung parenchyma, and pulmonary vasculature. So this inflammatory response to these noxious agents occurs throughout the airways, both proximal and peripheral, the lung parenchyma, and the lung vessels, lung vasculature. So what happens? So when there is a chronic inflammation year after the year, or you are exposed to the noxious gases or agents on a continuous basis or on a chronically exposed, then occurs a lot of changes in the airways, which results in the narrowing in the airways. And there is a also permanent increase in the number of the mucus secreting glands and the goblet cells, which leads to hypersecretion of these mucus as a sputum. So these patients will have continuous or more or less throughout the year sputum production. That's the pathophysiology of this. Now, if it does not stop here, let's say the inflammation continues, the noxious agents are continuing, and this will result into scar formation. There will be tissue damage, there will be fibrosis, there will be scar formation. So this scar formation in the long term results into the narrowing of the airway lumen. So you'll have a lumen which after a long period of chronic bronchitis will eventually become narrower. And there is a wall destruction of the alveoli, which leads to the further loss of alveolar attachments and the elastic recoil of the alveoli. We all know that the expiration, which is the passive process, is because of the natural elastic recoil of the alveoli and subsequently the whole lung. So when these destruction of these walls happen, then they do not recoil. So there is an expiratory outflow obstruction. The chronic inflammatory process affects the pulmonary vasculature also, and this causes thickening of the blood vessel lining, hypertrophy of the smooth muscles. So the blood vessels are thickened, they become narrower, There is a rise in the pressures of the pulmonary vasculature, which you would have often heard as pulmonary hypertension. So these patients in long term will develop pulmonary arterial hypertension. Next. So after the pathophysiology, we'll talk a little bit about epidemiology, how bad it is, what's the number across the world. So yes, as we all know, the data collection is poor in our country. It's not as robust as in Western world. So most of the data that we talk about on most of the things is from Western world data. Mortality for COPD has been increasing while the mortality from other diseases are actually decreasing. So this is a very serious matter. The other diseases we are able to control. The lifestyle is improving, the mortality is coming down, but for COPD actually has been increasing. If we talk about United States, it's the 4th most common cause of death in United States after the cardiac problems. If you look at the Indian data on the right side during this graph, the authenticity of these numbers cannot be exactly pinpointed, but they are more or less true representation of the situation in our country. So in 2006, India had around 17 million, the dark blue bar, around 17 million COPD patients. Whereas 10 years later, in 2016, it went up to 22 million. So a rise of 5 million in 17 million. So an approximate jump of around 30%. Now they say if this is the rate that we grow, the number of COPD patients in India will be 5 times or 6 times the population of whole New Zealand. So you can imagine the number, the magnitude of the problem, it's huge. And when the numbers are so high, obviously mortality is very high, the cost of treating these patients are very high. Next. Now, this is the cost of treatment of economic burden of COPD in India. Now, the yellow ones are the way it has been treated until now, as in individual brilliance, somebody treating like this, somebody treating like that, patients not going to hospitals in time. And the purple box bar is if we followed the standard guidelines. So it says that in 2016, the cost of treating COPD patients in India, it's just a rough estimate, was 35,000 crores. But if we had used the guidelines, if we followed the guidelines in the treatment and management and diagnosis and prevention, then the cost would have been only 4,000 crores. So you can imagine the amount of money that we spend if we do not follow guidelines, and the amount of money that is being spent after patients of COPD, right? So that's huge, huge. Today, I would imagine it's up to 50,000 crores. Next. So after the epidemiology, we'll talk about what are the causes. Sorry. So most of the causes of disease can be classified, well, in COPD case, it can be classified as environmental factors, as in the external agents, and the host factor, which can cause COPD. If we talk of the external factors, the environmental factors, smoking is the single most biggest cause of COPD in any population across the world. Interesting figures coming from developed world is that previously it was more men than women with COPD, but now it's reversing. It's now more women than men with COPD because the smoking has gone up in the female sex. So what does smoking do? When you smoke, the irritant chemicals, they depress the activity of the scavenger cells and they affect the respiratory tract's cilia, the ciliary clearing mechanism, thus resulting into the sputum being collected there and not being timely expelled. That's smoking. Occupational exposure, the prolonged and intense exposure to occupational dust and chemicals, household pollution, outdoor air pollution, They all can cause COPD. So these are the external factors. So basically it's the irritant, it's the noxious agents, either through smoking or through environmental, which could be industrial, which could be occupational, which could be chemical, which could be inside the home and outside air pollution. So that was the external reasons. The host factors, so there is a well-documented genetic defect where there is a deficiency of alpha-1 antitrypsin enzyme. This enzyme normally protects our lung parenchyma from external injury. So if there is a deficiency, it results into emphysema. So these patients, they develop emphysema. Next. So after causes, after epidemiology, pathophysiology, epidemiology, causes, now we come to clinical manifestation. How does a COPD patient present? Well, you all have would have seen hundreds and hundreds of COPD patients, and that's why it's even more important that we know in detail about them. So the natural history of COPD is actually variable, but unfortunately it is progressive. So some patients may present slightly differently, but the disease, if untreated, if not properly treated, is actually progressive. It will get progressively worse. So what are the clinical manifestations? Chronic cough is one of the primary symptoms of COPD. Sputum production, we know the mechanism, how it's produced, is another important standard clinical presentation. Dyspnea on exertion. So you have a patient who says he does a little work and gets breathless, and you think of heart as a cause, may not be. So it's even dyspnea on exertion is a very common presentation of COPD, which gets worse with exercise. Dyspnea at rest. Now this is as in a bad situation. If a COPD patient is dyspneic, even at rest, then you know that the disease has progressed horribly bad. The other symptoms could be weight loss. Why? Most of the time it's the dyspnea. People are not able to breathe properly. They will, refrain from eating, and because they are breathing with difficulty, so the large work of breathing actually leads to a lot of energy consumption, and so there is weight loss. These patients, especially the emphysema patients, they may actually have barrel chest. I'm sure most of you would have seen it. Next. This is a barrel chest, a hyperinflated fixed rib position. This is barrel chest. So this is seen typically in emphysema, but it can also be seen in COPD patients. So the normal one is a flat chest. Next, good. No, that's fine. So after the clinical manifestation, we'll see how we can prevent this disease. What are the preventions? Well, it's not that the prevention is impossible. What we need is discipline in life and consistency to treatment are the keys to achieving freedom from this chronic pulmonary disease. The single most cost-effective intervention to reduce the risk of developing COPD and stopping its production is to stop smoking. I cannot reiterate on this fact again. Healthcare providers should promote cessation of smoking by explaining the risks and personalizing it with the patient, that a patient may be at risk of developing it if he is a smoker. So smoking prevention is probably the single most, not probably, it is the single most effective intervention. Next. Yes, in prevention, you could also talk about occupational exposures being less, air pollution being less, household dust mites being less. But yes, what the single most is smoking. So what are the complications? Well, the complications of COPD are usually life-threatening. Sometimes they can be fatal. The first is the respiratory insufficiency. If it worsens and if it's not treated well in time, it will lead to respiratory failure. Well, I'll not go into details. You know what is insufficiency, what is failure. Next. So now that we understand the epidemiology, the burden of the disease in India, across the world, the amount of money involved in treating patients, the pathophysiology, the causes, the single most important cause, the single most important preventive mechanism. But you'll still have patients coming to you with COPD. So once you have a patient, so how do you assess them and do diagnosis? So the diagnosis and assessment of COPD must be done carefully, since the three main symptoms that we talked about was cough, dyspnea, and sputum production are common among other chronic lung disorders or pulmonary disorders. So an important factor is taking a detailed health history. As we talked, history will tell you whether they are a smoker or not, whether they have a occupational or environmental exposure, or if they have ever been diagnosed with some genetic defect. So a detailed health history. Further, we can do to diagnose them, we can do pulmonary function studies. Spirometries are done. ABG, all of you must be aware of it, that an ABG will give you a, well, not a diagnosis, but help you in diagnosing COPD patients. Patients will be hypoxic, they may have a higher carbon dioxide with raised bicarbonates. The other assessment tools that you can use is you can do blood tests. If you do a complete blood count or and a total and differential count, COPD patients or advanced emphysema patients, they will usually have increased hemoglobin. As a discussion, we will talk at the end why increased hemoglobin. Right? If they're asthmatic, we know it's an allergic situation, so you'll have a raised eosinophil numbers. ECG can also give you an idea about COPD patients. Long-term COPD patients will have a right heart strain pattern. As I said, because there will be pulmonary hypertension, the vasculature, the parenchyma of the lung, everything is involved. So it imparts a pressure on the right side of the heart. So you will have a right heart strain pattern. If you do chest X-ray, as we talked about in emphysema, you may have hyperinflation of lungs, flattened diaphragms, decreased vascular markings. They all can be seen in emphysema. In bronchitis, you'll actually see increased bronchovascular markings. Next. So after the assessment, we come to how to manage. So the management of COPD can be both medical or surgical, right? So I'm sure some of you must be thinking surgical management of COPD. Yes, there may be situations where we may have to resort to surgical management, but first we'll talk about the more common medical management commonly done with the medicines. So that's called as a pharmacological therapy. So the most common thing that is used in COPD patients is bronchodilators. So to relieve the bronchospasm and reduce the airway obstruction, thus allowing more air to get evenly into the lung spaces and improving the alveolar ventilation. So we all know we use Astalin, Nipratropium, Duolin, all these bronchodilators, Foracort, LABA, SABA, all these you must have heard. So these are the bronchodilators which relieve the bronchospasm. The other drugs which are commonly used are steroids, both through inhaled route and sometimes through oral route. So a short trial course of oral corticosteroids may be prescribed in certain patients to improve the pulmonary functions. There are other medicines which are used, like most of the time we suspect that there may be an infection, or an infection may have precipitated a case of COPD. So antibiotics are quite commonly used, mucolytics, antitussives, which are anti-cough. Sometimes even narcotics and opioids have been used to stop the cough. Next. So as I said, bronchospasm and inhalers are the first line of therapy. So few things from the nursing point of view that I want you to take home is those patients who are using this MDI, all these MDIs are pressured meter dose inhalers. You press them and there'll be a stream of drug coming out of it. So in a hospitalized patient, they should, or even patients who are at home, they should be given a spacer device. Now, I'm sure a lot of you have seen spacer device. Most of you would have seen it. What it does, how it helps is that it increases the lung deposition of medication. So you press it into the spacer and then the patient breathes on his own. So it increases the lung deposition of whatever medicine that you are using. It prevents or rather reduces the oropharyngeal deposition. So not much drug will be deposited inside your mouth, but sometimes when they take directly into the mouth, a lot of drug sticks to their back of the pharynx or to their tongue. So if less drug is deposited in the oropharyngeal space, so you'll have less local side effects of oral candidiasis, which is quite common in these patients who are taking steroids. Next. So that was a standard management of a COPD patient who may come for a regular treatment or who may be being treated at home. But how about when they come to hospital with exacerbations of the COPD? So the first line therapy in management or exacerbation of COPD is the optimization of the bronchodilator that the patient may be taking from before, or you add new ones, or you add a combination of new ones. But an optimized bronchodilator therapy is the first line therapy. Patients may require hospitalization if there is severe dyspnea which is not responding to the standard management, or if the patient is now becoming confused, dull, drowsy, lethargic. You can see that the patient is, kind of giving up, there is a respiratory muscle fatigue, the chest wall movement is going in the wrong direction, or if there is peripheral edema, which means that there's a heart failure setting in, resulting into peripheral edema. So all these form an indication for admitting such patients in the hospital. So once your patient is in the ER, so supplemental oxygen therapy is given. And obviously you do a rapid assessment to see if this exacerbation is life-threatening. Antibiotics have shown to be of some benefit to patients with increased dyspnea, increased sputum production, and the purulence of the sputum. So the more purulent, the more the volume, worsening distress, respiratory distress. These are the patients who also need antibiotics, but we kind of often use it in most of the patients. Next. So talking about oxygen therapy. So a COPD patient comes to your ER with worsening dyspnea, is quite breathless, is a little confused, drowsy, thak gaya, tired lag raha hai, bol nahi pa raha, sweat kar raha hai. So yes, you obviously give oxygen. But this oxygen therapy is given to correct hypoxemia, the low oxygen saturations, not to prevent or treat breathlessness. So there may still be breathlessness, but with oxygen, we will only treat hypoxemia. It should be prescribed with caution in patients with COPD after ABG assessment. If anything from this presentation of today, this discussion of today, if there is one message that I want you guys to take home, is to take this slide home, that COPD patients usually will have low oxygen saturations or low partial pressure of oxygen in their blood, and slightly raised carbon dioxide, right? So COPD patients, they predominantly, their respiratory center in the brain is driven by the hypoxic drive. So low oxygen keeps driving their respiratory center in the brain rather than the raised CO2 drive or the hypercapnic drive, right? So if these patients are breathing because they are slightly hypoxic, and if you give them too much of oxygen, so that hypoxemia is corrected, suddenly these patients will stop breathing or they will slow down their breathing to dangerous levels. Okay, so we only aim for a saturations of 90-92, not more than that, because we want these patients to continue to breathe If you give them too much oxygen, it will suppress their brain, they'll stop breathing, and suddenly you'll have a patient who came breathing, who was little distressed, but now suddenly has stopped breathing. That's because of too much of oxygen. Next. So as I said, medical therapy, we talked about bronchodilators, we talked about using spacers, we talked about steroids, we talked about exacerbations, we talked about oxygen therapy. Surgical management. Sometimes bad COPD patients may only be left with a surgical option to improve their outcome. Bulectomy. Now, what is bulectomy? It's the removal of a bulla. Where do you find bulla? You find bulla in emphysema patients. How do you, so those patients who develop a lot of bullas are multiple alveoli where walls have broken and small alveoli have become a big alveoli. Now, if you break too many alveoli and make a big ball balloon, your area of gas exchange reduces, right? So they are called bullous emphysema. So sometimes to reduce the dyspnea and improve the lung function, patients may require bulectomy. There's also something called lung volume reduction surgery, which is basically a palliative surgery when there is homogeneous disease or a disease that is in one part of the lung, not throughout the lung, then you can actually chop that lung off to reduce the burden on the rest of the lung. In worst case scenario, lung transplant can be an option in end stage emphysema. Next. Next. Okay. So now here we come. So we talked about the disease per se, the treatment options available that can be practiced or used in case of a COPD patient. Coming to nursing management. Okay. So the first thing that we do is we assess the patient. So nursing assessment has to be done very quickly, rapidly, yet it has to be accurate. So it has to be done rapidly and accurately. So how do you do? You remember we started with taking a health history. So assess the patient's exposure to risk factors. So you take a history, they'll tell you what are the risk factors, if it's a smoker or occupational exposure or environmental exposure. Assess the patient's past and the present medical history. If the patient tells you or the family members, they tell you that he has had a similar admission last Diwali also, Diwali before that also. So you know that this guy is developing a exacerbation of his COPD every Diwali or every time the winter comes or the season changes. So assessment of the past and the present medical history. Look for the signs and symptoms of COPD and their severity. So we talked about the signs and symptoms. Ask the patient's knowledge of the disease, whether the patient is aware of it or not, that what disease. Most of the time, because it's a chronic condition, patients will tell you that I have COPD, it gets worse in this month of the year, right? So that's from where you start. Okay, he normally gets like this. Assess the vital signs. Listen to the chest, the breath sounds, the patterns of breath sounds. Next. So after nursing assessment, obviously a diagnosis of COPD would be made depending upon multiple data gathered by the other members of the healthcare, the doctors and others as well. So what are the areas that we see? What do we diagnose? What do we do? So impaired gas exchange, we know is happening there. Ineffective airway clearance. So this leads to bronchoconstriction, increased mucus production, ineffective cough and other complications. Again, ineffective breathing pattern related to shortness of breath, mucus, there may be bronchoconstriction, and there may be present airway irritants. Patient is too tired, too drained out to look after himself, will be like flat line. Activity intolerance, they would prefer to sit in the bed or not do anything because of hypoxemia and poor ineffective breathing patterns. Next. So once you have done your nursing assessment, you have come to the diagnosis. Then we set few of our goals. What are our goals in this case? And how do you plan to reach them? So the goals to achieve, yes, we want to increase or improve the gas exchange. We want better oxygen. We want lesser carbon dioxide or normal carbon dioxide. You want airway clearance, achievement of airway clearance, improvement in the breathing patterns. These are our nursing goals. Improvement in gas exchange, achievement of airway clearance, improvement in breathing pattern, independence in self-care activities of the patient, improvement in the activity intolerance, as in improvement in the activities. Oxygenation, ventilation are adequate. The patient is able to breathe enough or adequately, or his oxygenation is enough to meet his self-care needs. Nutritional intake is very, very, very important to meet the caloric requirements of these COPD patients, where the work of breathing is very high and they burn a lot of energy. If there is an infection which is suspected or treated, so our goal is to treat the infection or prevent the infection. The disease process, the prognosis, the treatment plan, all must be well understood by the nurses and also by the patient and the family. And you have a plan in place to meet the needs after discharge. So these are our goals to achieve when we have a patient of COPD to look after, starting from improvement in gas exchange to what happens when the patient goes home after discharge. Next. So that was the goals. Now, what are the priorities? The nursing priorities is to maintaining the airway patency, assisting with measures to facilitate gas exchange, improving the nutritional intake, preventing complications, infective or non-infective. These patients are bedbound, they can develop bed sores, they can develop DVTs. They are very high risk patients for DVTs and secondary infections. You need to understand that this is a slowly progressive condition. So magic wouldn't happen overnight. We need to discuss this with the families. The nurses should have their own expectation. ये धीरे धीरे improve करेगा. Provide information about disease process, prognosis, and treatment regimen. So not just understanding, but also providing this information to the family and the patient. So these are our priorities. Next. So we set a nursing goal, we set nursing priorities. Now, what are the interventions? Priorities just won't do. How do you reach them? How do you achieve those goals? One, patient and family teaching is an important nursing intervention. Well, also an invention. But no, patient ka teaching and family teaching is a very, very important nursing intervention. The nurses can do that best. So coming back to nursing, what to achieve. So achieving airway clearance was really important. So how to achieve airway clearance? The nurse must appropriately administer bronchodilators and steroids to the patient and be alert for any potential side effect of these medicines. So appropriately administer the medicines is the most important word, because as I said, when you're using the inhalers with or without spacers, nebulizers, so an appropriate mechanism, care of those instruments, the best usage of those instruments is what is being an appropriately administering drug. And also being aware of the potential side effects. 2-3 दिन steroid देने के बाद they will have a bad taste in mouth. They may develop oral fungal infections. So there are certain drugs which cause hypokalemia, which cause tachycardia. So being aware of these side effects. The other thing regarding maintaining airway clearance is direct or controlled coughing. Now, what do you mean by that? 1 second, sorry. Direct or controlled coughing, as the name suggests, is a coughing which is done by the patient out of his own choice to clear his airways. So the nurse instructs the patient in direct or controlled coughing, which is much more effective and less energy consuming. So if a patient on his own makes an effort to cough with a plan, so that's called a direct or controlled coughing. Instead of you having patients where, suddenly they go into a bout of coughing and start coughing uncontrolled or undirected. So this results into wastage of energy and not really much benefit happens in terms of airway clearance. Sorry, just one second. Sorry. So this is how we achieve airway clearance, most importantly by doing a direct or controlled coughing, apart from giving the drugs appropriately. Next. So how do we improve the breathing pattern? You train the patient, inspiratory muscle training, right? So it's like training the patient not to use their abdomen, but to use their chest wall muscles and diaphragmatic breathing. Inspiratory muscle training, diaphragmatic breathing. Diaphragmatic breathing reduces the respiratory rate, increases the alveolar ventilation, and sometimes helps expelling much air during expiration. So they will have a much better breathing if they're trying to breathe like that. Also, pursed lip breathing. I'm sure many of you would be aware of it because a COPD patient in distress will be breathing. No, that's not what we want. We want them to have a controlled, slow breathing with long expiration, slow expiration. So if they have a pursed lip breathing helps slow expiration, prevents the collapse of small airways. It works like a PEEP that most of you are aware of, and controls the rate and depth of respiration. So how do you improve breathing pattern? You do inspiratory muscle training, you train them how to do a diaphragmatic breathing, teach them to do pursed lip breathing. This will improve the breathing pattern. Next. Next. Okay, so other important, have we gone 2 slides? Go back one
So
more.
this is the slide. So this is the slide, sir.
Okay.
Next is this one.
So the third was how to improve their activity or to improve the activity intolerance. So we try and help them as a nursing manpower to manage their daily activities. Daily activities must be paced and planned throughout the day, right? Instead of, morning physiotherapy team coming at the same time, others also coming, same time you're giving them bed rollover or wash and clean. So one must plan the daily activity throughout the day and use support devices so that these patients can reduce their energy expenditure. So one time of the day you do too much of activity, they're tired and drained, and the rest of the day they're lying in the bed. No, it should be well planned throughout the day to decrease the energy expenditure because they're, as it is, spending too much of energy. Exercise training can help with strengthening the muscles of the upper and lower extremities, and it can help them with exercise tolerance. More important with patients who are about to go home or who are at home. Walking aids can be, these patients who are sitting at home, not getting out of the bed, or patients even in wards, just sitting on bed. So you help them to walk with sticks and ambulatory supports. Next. To monitor and manage potential complications. So now, if we look at complications, we know if the oxygen saturation drops, the patients can end up on ventilator, they can have secondary infection and so many things. But the things that are usually missed is the major cognitive changes. These patients who are so much limited physical activity, they're hypoxic, they're not able to breathe well, they're always tired. So these patients, they start developing anxiety and depressive characteristics. They develop personality, behavior changes, they have memory impairments. So these all must be looked into and try to sort it at the first instance that they are noticed. Monitor pulse oximetry values. Pulse oximetry values are used to assess the patient's need for oxygen and administer supplemental oxygen as prescribed. Preventing infection, probably the most important thing. Apart from encouraging the airway clearance, at the time of discharge or when they are too good to be in the ward, the nurses should encourage the family and the patients to get immunized against the respiratory viruses, the bacteria that we have vaccines available. So they should get vaccinated with these things so as not to get another respiratory infection and worsening of their chronic bronchitis. Next. So, from nursing point of management, we have treated the patient, we have improved the care of the patient, we have looked into the interventions that can be used. So after you've done all this in any sort of patient, be it a home COPD, be it one in the hospital with mild or moderate, or somebody in the ICU, we need to identify at the end that we need to evaluate that the whole effectiveness of the care plan that you had used, what was the effectiveness of that care plan? That has to be measured. So the effectiveness of the care plan would be measured if the goals were achieved in the end. And the patient identifies the hazards of cigarette smoking. So patient now understands that what are the drawbacks of smoking, identifies the resources of the family, the patient, which can help them in stop smoking program. If they're already home, if the patient has already registered himself in the smoking program, stop smoking program, minimizes or eliminates exposure, doesn't go to those areas. He talks about the need of fluids to keep yourself well hydrated, is free of infection, is practicing breathing techniques of NOD, and he does activities which has less shortness of breath. So if these are the things that the patient is doing, then that's the effectiveness of your care plan. So this is how we evaluate our own performance. Next. So once they are going home, we are setting some goals, giving them home care guidelines, setting goals. If COPD is mild, so our idea is to gradually help the patient increase exercise tolerance and prevent the further loss of pulmonary function. If they are moderate or severe, then the goals are to protect whatever the function the patient has and not get it worse. Temperature control is something that you must guide your patients at home or at the time of discharge, that they should not be exposed to extremes of temperature, hot and cold. Activities, physical activities should be kept in moderation, not too much, not too little. And they must keep doing the breathing retraining exercises to improve their functional status. Next. As I said, all said and done, you have done so much, but you need to document everything. So document is an essential part of the patient's chart, which helps in the clinician, whoever the patient visits next time, to understand what happened and what was done. So your documentation should also include the initial respiratory rate, the type of breathing, the character of breath sounds, the rate, the secretions, and the lab and neurological findings. You document at the time of discharge the conditions which can interfere with oxygen supply, plan of care, how much oxygen was the patient being given, how was the patient's response to all these teaching and performances. So giving them a plan of care at the time of discharge. Next. That was it. So yeah, I think I've taken a lot of time.
It's okay, we have another 10 minutes in hand, almost
Okay.
8 minutes. So I would request all of them to, yeah, we have already started, we're quite aware. So kindly put your answers in the chat box.
So your first question, as Dr. Gupta said, or well, as we are asking, is as a cause of death in United States of America, COPD ranks at which level? 1, 2, 3, 4. I'm sure this is the easiest question to answer.
And I think, Dr. Mishra, everyone were quite awake.
Yeah, so
during
that's
the-
why this question was whether they're awake or sleeping.
Yes. So maybe we can proceed.
Yes. So the next question is two diseases which have common to the etiology of COPD. Well, again, this is a very simple question that I put, but there will be a discussion at the end of it.
Hmm.
So, common etiology of COPD, asthma and atelectasis. Well, we'll discuss why not. Chronic bronchitis and emphysema, probably yes. Well, certainly yes. Pneumonia and pleurisy, do they not have common etiology like COPD? Tuberculosis and pleural effusion. We'll see to it. Can we come to the explanation next, please?
Yes.
Yeah. So, well, we all know chronic bronchitis and emphysema is the answer. They belong to the old classification of COPD. Whereas, if we talk about option A, where I had said asthma, is a chronic pulmonary disease, but atelectasis is not. Right? Pneumonia and pleurisy are not classified under the COPD. And obviously, tuberculosis and pleural effusion are also not chronic pulmonary diseases. Okay, shall we move to next?
Yes. Next.
Okay.
Any questions from the house? Please put in the chat box if anything. Yeah. Yes, Dr. Mishra, you may continue.
Yeah. So the question is there for everybody to read. The underlying pathophysiology, I talked about it multiple times, is what in COPD? Inflamed airways that obstruct airflow, mucus secretion that obstructs airways, alveolar cell wall destruction, or variations in all of the above. Yeah, I can see a lot of people giving very enthusiastic, correct answers. That's fantastic. Seems like I have done a good job.
There is a question in between. Okay, we'll take up the questions at the end of the quiz, right?
Yeah.
Okay.
Next, we'll try and explain this. So, yeah. I don't think I need to repeat again, but inflammation, hypersecretion of mucus, alveolar wall destruction, they're all the part of the COPD. There's involvement of parenchyma, the proximal and peripheral airways, pulmonary vasculature leading to pulmonary arterial hypertension. So they all are part of the pathophysiology of the chronic obstructive pulmonary disease. Next.
I request all of you to please answer, even if it's wrong, please kindly answer. The abnormal inflammatory response in the lungs occurs primarily in the airways, parenchyma, pulmonary vasculature, areas identified in all of the above. I think we can move to the explanation.
Yeah, so the correct answer is that both the airways, the parenchyma, and the vasculature, they are all involved in the pathophysiology of COPD.
The most important environmental risk factor in emphysema is air pollution, allergens, infectious agents, cigarette smoking. Here there is a mixed response between air pollution and cigarette smoking.
Yeah, I can see a lot of, there's a few B as well.
Yeah, there's a few for allergens as well. So I think the explanation again would be very important in this. Dr. Mishra had already mentioned that cigarette smoking is the most important cause of COPD besides the other causes, which are pollution, the environmental occupational hazards, allergens, etc. So if we see the question is the most important cause. The most important cause will be cigarette smoking. So now we'll just take up the questions which were in the chat box. Dr. Mishra, are you there?
Yeah. Sorry.
Yeah. So first, the question was clinical symptoms of asthma in a pediatric patient.
Yeah. Clinical symptoms of asthma in a pediatric patient. Well, you see, as I said, COPD is divided into chronic bronchitis and emphysema. But if we talk of the bigger picture called chronic obstructive airway disease, that also includes asthma, which is primarily an allergic response to an allergen causing the similar obstruction to the expiratory gas flow. So the presentation is again similar even in kids, that they'll be short of breath, they'll be dyspneic, they may have bad cough, but because kids have very less energy sources and reserves, they can become cyanotic, hypoxic very fast and can become drowsy and dull and unconscious. So that can be one of the presentations of an asthmatic child.
Okay, so basically, if I sum up, so asthma is basically a disease not similar pathology, but similar presentation, but it is seen from childhood, right? It is seen more in pediatric patients. COPD is seen in adult from adolescent, from in adults. Okay, the next question is the ABG findings and ventilator settings for a COPD patient.
You want to answer it, Reshu?
Yeah, so the ABG findings, if I see, as we have discussed in the pathophysiology, in the mechanics, or in the the discussion, that there is constricted airway. So COPD patients, they have a difficulty in expiration. So they retain more of gas. So they retain more of carbon dioxide. So usually in the ABG, if it's an acute exacerbation COPD, they will have a high CO2. In acute exacerbation, they have a high CO2 going to CO2 narcosis. So accordingly, we have to set the ventilator settings as well. These patients are not hypoxic unless and until they have over and above infection or a pneumonia. So basically, our aim of ventilation should be to increase their expiratory time so that they can let out, so they can release the carbon dioxide. Since they are hyperactive airways which are constricted, so they need to release, and we need to have a prolonged expiratory time. So maybe in ventilator settings, if we are setting that IE ratio, as we do in ARDS in a severe hypoxic type 1 failures, we do it, maybe we are more close to 1:1. Here, maybe we can go up to 1:2.5, 3, in fact to 4 as well. Okay. So are there any specific changes in the COPD, changes in ECG in COPD patients? Yes, there will be a right heart strain pattern, because chronic COPD patients, they have usually they present with a right heart failure, so they might have a right heart strain pattern.
Yeah, just being a little specific about this particular question. Any specific change? So right heart strain pattern, as Dr. Gupta is trying to say, is that you will have changes on the right side of the heart, meaning thereby you can have a right bundle branch block, you can have a peak P waves, you can have right axis deviation. So these are the changes, specific changes that you may see on ECG as a sign of right heart strain pattern.
There is another question, why is there increased hemoglobin in COPD patients?
Yeah, I'd asked to ask this question, so somebody did. Now you see, the primary, as Dr. Gupta said, is there is an obstruction to the airflow, so carbon dioxide is retained, and because of that, so you become hypoxic, right? You're not completing your ventilation, so you are keeping low oxygen. Now, when your body, also, you remember I said, don't give too much oxygen to these patients when they come with hypoxemia, is that these patients are normally slightly hypoxic. So their oxygen content in the blood is less. Now, the content may be less, but not content. The partial pressures may be less, but we need enough oxygen to be delivered to the rest of the body, the rest of the tissues, the heart, brain, liver, kidney, etc., for them to function well. Now, if the oxygen saturations are keeping low, so what are the other things that we can do? So if you by any chance remember the formula of oxygen content of the blood, which says that the oxygen bound to the hemoglobin as well as oxygen dissolved in the plasma. So plasma volume, the dissolving depends on the partial pressure, but oxygen is carried with hemoglobin. So if you increase the hemoglobin concentration, there will be more oxygen in the blood. That's why these COPD patients will keep, if you look at their RBC count, that's very high. That's how they increase their hemoglobin. And that is a kind of protective compensatory mechanism of the body to have more oxygen in the system, even if the saturation is low. I hope I'm
Basically,
clear.
since these patients are chronically with low oxygen, so in the body there is more of red blood cell production from the bone marrow. So basically, that is why these patients have high hemoglobin. In nutshell, what Dr. Mishra have explained, that is in nutshell, like they are chronically hypoxic, they are chronically having low oxygen. So as to deliver oxygen in the other parts of the body, they need more of oxygen. So how do they do it? By increasing the red cell production from the bone marrow. And so they have high oxygen. Okay, how to titrate IPAP and EPAP value in COPD patient? Should I take it?
Yeah, go on.
Okay, so how to titrate IPAP, and we need to have a difference in the IPAP and CPAP of at least 4. More the difference, better is the exchange. So if we have a difference, so we may go on increasing the difference. But minimum we need to maintain a difference of EPAP and IPAP and EPAP of at least 4 or more, not less than that. Okay, and how to write it, this is very important when we are putting a patient of COPD on NIV. As Dr. Mishra had mentioned in his slides, we need to first educate the patient. We need the patient to understand why this machine is being given, and once you make him comfortable, you make him okay and adjusted to the settings of the machine, then believe me, the patient himself will again and again keep asking the machine. We do not need to restrain the patient. We do not need to tie him up and do not need to tell him, you have to take. He will himself take it once he feels, okay, this is giving him some relief. So that is why if when you go back to your ICU, you always see there is a ramp, there is a button, there's a, in every ventilator when you put on the non-invasive ventilation, there's a ramp. That means how much time the patient will take some time to get adjusted, whether you need that patient to take 5 minutes time to get adjusted. The track, that auto track is there, and sometimes you can set the time. So always it's very important to take care of that. When you put the patient on NIV, you set the time to patient gets adjusted to the settings. Okay. So always what we do in our unit is we always allow the patient to hold the mask himself so that it is comfortable, and then you try to tie the mask, you fix it the mask. Okay. Should we use fill-in? I noticed a lot of doctors not preferring. Fill-ins, basically in earlier days we used to use dairy fill-in, which have lot of side effects, basically cardiac side effects. It causes tachycardia, it will lead to arrhythmias. So filins have gone absolute. Those dairy filins, which helps in the acute stages. In chronic patients, in chronic COPD patients from the medicine department, from the OPD, patients are prescribed abifilin, those isomers of filins, which are not recommended for in any acute settings. So that is why in the acute settings, the role of filins are not there. But maybe when you are discharging the patient in the chronic COPD patients, you may give filins, but those isomers, not terifilin.
Okay, so a lot of questions.
Yeah.
Hmm.
COPD patients occurs high PCO2, how to wash out. We have already discussed by increasing the expiratory time. Any other questions which we have missed? I don't think so.
No, we're fine.
So few points I would just like to, as Dr. Mishra have given a very descriptive thing. It was very informative. So few take-home messages will be what he had mentioned in the first few slides, that oxygen, the SpO2 target. We need not give patients of COPD continuously oxygen and killing his drive. That is very important. Many a times, especially from the nursing side, I'm telling, we always have a habit of, as soon as the patient lands up into the ICU, you start him on oxygen. So this is very important to note. If the patient is on COPD, does he need oxygen or not? You have to question yourself each and every time. Then NIV, we have already discussed in details. Achieve the airway clearance. It is very important. By achieving airway clearance, that means you have to clear his airway either by postural drainage, either by his chest physiotherapy, either by encouraging the patient to cough and clear his airway, the other techniques, and improve the breathing pattern, as Dr. Mishra had very precisely and in clear, he had discussed it.